probably.
Yes. So the whole idea of needing funding, which we've discussed since we do such great work, Lori has done amazing things in her community. This is a way to present the data of, this is evaluating the actual intervention that's used at ATTACH and the other organization that Lori heads. So this can be used to present information to any decision maker or anyone that we would need to speak to show that we do work, like the therapy does work and we deserve some funding.
Wonderful, thank you. So Victoria completed her capstone placement with us, and this was the main project that she worked on, and she worked on it in consultation with Dr. Paul Frewen out of Western University Hospital, who's a leading expert in the areas of traumatic stress. So I was really grateful to have him involved. I'm really grateful for the work, because it was a lot of work that Victoria put into this to come up with the outcomes. So I'm going to share her presentation.
Lori, let's just share too that Victoria has just recently graduated and we congratulate her.
Oh,
Yes.
thank you.
Congratulations. It's an accomplishment.
Thank you.
I will be presenting on the results of the evaluation that was performed on the ITATM. So this evaluation assessed whether or not the intervention was working, or rather whether or not the intervention decreased the negative effects of trauma for clients. In this presentation, we will be describing the ITATM. We will look at process measures. Finally, we will look at outcome measures that we looked at for the program evaluation, and we will close with a conclusion. The ITATM stands for the Integrative Trauma and Attachment Treatment Model. It is essentially an intervention that is used for clients who are suffering from trauma and attachment dysregulation. It was created by Lori Gill. It, simply put, is a layered integrative model that regulates the body, brain, and mind simultaneously using sensory processing, somatics, CBT, and many more components. The first process measure that we looked at was client satisfaction level. So clients were given a questionnaire at the end of every session, and it asked them things like, I felt heard, understood, and respected, or I did work on or talk about what I wanted. And essentially, clients would respond either yes or no, yes being a positive response and no being a negative response. And as you can see here in this graph, we are getting lots and lots of positive responses from clients. The second process measure that we looked at was number of sessions attended. The fewest number of sessions attended for a client was 3, while the most sessions attended by a client was 80, and the average number of sessions was 22. The outcome measures that we looked at were scores on assessments. Assessments are essentially questionnaires that clients will fill out before their therapy and after the course of therapy is complete. Now, these questions will be the same both times, but the hope is that the scores on these tests will decrease because that is indicative of decreasing symptoms. So we looked at 3 different assessments, the TSI-2, the TABS, and the DERS-18. And again, we want to see that the scores are decreasing from the first time the client took the test to the last time. And also for the outcome measures, we did some statistical tests, which we will look at too. The TSI-2 looks at a number of different scales, as you can see on the right-hand side here. And in the left column, we have the names of the scales. And in the right column, we have the average reduction scores. So essentially, the average reduction scores are based on the difference between the average scores for the first measure or the test that clients took at the beginning of therapy and the average score of the last measure. So the test the clients took after their course of therapy was complete. So you can see that the differences range from about, we have 5.25 being the lowest, and then we have 12.11 being the highest. So we are seeing some differences. And on the left, we see a more visual representation of these reductions. So the blue is the first measure, so the first time the client took the test, and the white is the second, or sorry, the last measure. And as you can see, we are seeing those differences. So the bars are going down, some maybe not as much as others, but a reduction in symptoms is always good. And the TSI-2 also combines those scales that we just saw on the last slide into 4 different factors. So you can see the table on the left here. We have the 4 factors, and then in the right column, we have the average reduction scores ranging from 3.98 to 12.64 being the highest. So again, the visual representation is here in the bar graph, and we really do see that there is that drop, which is good news. And we did a Parity Test, and we found that all the scales and factors are significant. The tabs looks at a number of different subscales as well. For this program evaluation, we looked at 3 subscales. In this table here, we see that the changes range from 4.31 to 5.73. And again, the bar graph, we can really see that drop. So from the blue being the first measure to the white being the second measure. And according to the creators of the tabs, the 2 here, the safety of others and lack of self-control. So although 5.24 and 5.73 may not seem like a huge difference, the authors do say that this is indicative of a large statistical change. And even safety of self, we have a 4.31 change, and the authors say that this would be a moderate statistical change. And again, we did this t-test, and we also found that the changes from the first measures to the last measures are significant. The DERS-18 is another test that looks at several different subscales. For the purposes of this program evaluation, we looked at 3 of them, as you can see listed here on this slide. And you see that these different scores here, so ranging from 1.05 to 2.15, those do seem quite low compared to the other reduction scores that we've seen. However, the DERS-18 doesn't really have any rule for cutoff scores or how big a reduction needs to be to show that there has been a change. The DERS-18 really looks at trend over time. So here is a graph showing the trend over time. So for this test, we actually provided clients with it 3 times. So they would have taken it before therapy, halfway through therapy, and at the end of their course of therapy. And again, the DERS-18 really just wants to see that the trend over time is showing a reduction in scores. So the lines are going down, meaning that this is a real change according to the DERS-18. So for each of these, we are seeing a decrease overall. And we did do our own parity tests for statistical significance, and we found that each of these 3 subscales were significant. In conclusion, the 3 assessments show that the average scores are decreasing, meaning that client symptoms are getting better from their first session to their last session. We also see that the changes in scores are statistically significant. And what's not listed here, which is something worth mentioning, is that client feedback has been very positive. So we are seeing that the intervention is successful at decreasing the negative effects of trauma. Thank you for your time.
All right. Thanks very much, Victoria. I'm just going to add two things, Gail, sorry to go off script, but I just want to highlight a couple of things from a clinical perspective, or just kind of explain something else. When Paul reviewed this, when we were looking at this, and I think it's important to highlight, this is a very real presentation of complex trauma. So again, we're not going to see everybody walking out of treatment with us healed. We are looking to reduce the intensity. So when you saw that 12.1 reduction in tension reducing behaviors, that's what Cassandra was talking about, the suicidality, 10% reduction, right? So the tension reduction are high risk, the, engaging in high risk behaviors or potentially dangerous things or self-harming, like things that are shifting what's happening inside of me. That shift is happening, so it's no longer feeling as needed. The area that we see the least change is somatics. And I think the reason for this is this is our embodiment. When people start with us, and we see this when we look at the dissociation scales as well, they are largely not embodied. They're not feeling their feelings. They're not feeling their body sensations. They don't want to be. Right? Why in the world would they, with the tremendous trauma that they've experienced? It's incredibly painful. But as we do this work and we reduce the arousal, people become more embodied. So we actually see sometimes elevations in those areas, because as I'm starting to feel my feelings more fully, and I'm usually excited at this point, and sometimes my clients are looking at me saying, why do you look happy? And I'm like, because feeling is healing, and it will not last at this level. It will shift. So those were just a couple of things that I wanted to highlight, that, attachment is pervasive. It takes time to shift. Trauma, when we have layers and layers and layers of trauma, takes time to shift. But we are able to see really significant shifts even in, short periods of time. So sorry to interject there. I'll turn things back over to you, Gail.